interesting people from across the HLA community to share with us their ideas and their innovations and hopefully bring them to a global audience. Many of the topics come from our community, with scholars and faculty expressing an interest in many of the discussions that we're about to have. HLA programs are built on 6 pillars. The leader is an innovator and entrepreneur, the leader is a communicator, the leader is a manager, the leader as a negotiator, the leader as a follower, and the leader as a philosopher. If you are interested in becoming a HLA scholar, why not get in contact? Many of the episodes in HLA Live will cover one or more of these important pillars. The HLA team consists of Pedra, Eamon, Tim, Riddy, Alistair, Adil and Trisha, and a range of other HLA scholars and faculty. This week's episode is on health equity, hosted by HLA Live lead Pedra.
Thank you for joining us today. Today's episode is on health equity. I'm joined today with an amazing set of speakers, which includes Professor Neena Modi, the incoming president of the BMA, and a consultant in neonatal medicine, Professor Azeem Majeed, the head of the Department of Primary Care and Public Health at Imperial College London, and finally, Dr. Habib Naqvi, the director of the NHS Race and Health Observatory. So, when it comes to health equity, we usually have this image that comes to mind. But why exactly is health equity important?
Health equity is important because as a society, we want to try to achieve diverse health outcomes for all our populations. So whether you're poor, rich, whether you're educated, not educated, an immigrant or a native-born resident of the UK, we want to try to ensure that everyone has the best quality of life and best life course that they can. As part of being a just and fair society.
Well, health equity is really important because we know of the disparities that exist across society in relation to health. They exist on a number of different measures or social determinants. The one that I've been most interested in over the last decade or so has been the determinant of race and ethnicity. That, for me, has been a key focus, and the disproportionate impact that we're seeing at the moment with regards to COVID-19 and the pandemic of coronavirus has, I guess, shone yet another light on the disparities and the health inequalities that we're seeing for our Black and minority ethnic communities.
Thank you. And so, when we look at health equity across the world, each country differs from each other in terms of its inequalities, its resources. And so, as the next generation of healthcare professionals, how should we think about health equity in our careers, and how will it affect our career choices?
So I would like to encourage everyone to think about the determinants of health. And as I've already said, I think we need to focus both on prevention as well as treatment. And very often prevention gets forgotten about. So if we're taught, and health care and health systems are framed in the context of a health service. So in the UK, people talk about the NHS as shorthand for everything that's to do with health. But that is probably not helpful, because the NHS isn't responsible, for example, for air pollution. The NHS isn't responsible for climate change. The NHS isn't responsible for the tobacco industry, the fast food industry. The NHS is responsible for a very, very important but very narrow aspect of what determines health in the population of the UK. Now, if you take that analogy around the world, you'll see how perhaps the best level at which to think about this is to think about the determinants of health. As soon as you start thinking about the determinants of health, you realize that it actually goes beyond the health system. It's not like, I want to buy something that's going to make me better, so I'm going to go to a supermarket and I'm going to buy health treatment X off the shelf. And that brings in the commodification of healthcare and why this is such a damaging way in which health it has been viewed and is being viewed around the world.
Thank you, Neena, and thank you for bringing up the social determinants of health, because this leads on to my next question. So coming back to you, Habib, how should we, the healthcare professionals, tackle the social determinants of health? What opportunities are there for us to do this?
Well, the fact is that ethnic inequalities are evident in relation to access, experience, and outcomes in areas as diverse as genetic counseling, artificial intelligence, maternal health. And yes, I guess these disparities are compounded by the higher prevalence of disease conditions that we all are familiar with, including cancer, diabetes, cardiovascular disease, mental ill health. And of course, as I mentioned before, the disproportionate impact that COVID-19 is having on our Black and minority ethnic communities is there for everyone to see. I guess this country is well placed to tackle these disparities because of a number of different factors. Firstly, we have a long history of migration into this country. Secondly, we have a well-established and growing Black and minority ethnic community. Thirdly, we have a robust legal framework in terms of both the Equality Act and the health inequalities duties. And we've always had a kind of a high investment in health research. However, responses to health inequalities to date have either been fragmented, confused, or costly. And whilst specialist units, think tanks, commissions, and academic institutions have paid attention to this agenda, we know that the outcomes have largely focused upon theoretical recommendations with little emphasis upon practical implementation on the ground.
So what are we addressing now that is different to what we have addressed in the past?
So the fact is that we need to do things differently in order to get a different outcome. If we keep on doing the same thing, we will always get the same outcome. And that's why we need to move away from what we have been doing or trying to achieve over the last few decades by focusing on the root causes of the disparities that we see, rather than just looking at the superficial, high level, surface level factors. We need to look at what impact does differential attainment within education have, for example, on the life chances of different communities across society. We need to look at research funding, for example, and the allocation of research funding when we look at ethnic minority researchers compared to other researchers, and what's going on there, for example. So there are a lot of questions that need answers, and we hope that we can tackle those questions, those challenges head on over the years to come.
So this brings me to my next question. How should we address those issues that are not exactly within our job titles? Neena, I'll let you take this one.
So again, I would say let's start with the premise that I think every healthcare professional would agree that our obligation, our duty, our responsibility, what we're trained for is all about trying to achieve healthy people, whether it's a patient in front of us, whether it's a population, but our professional responsibility is to improve health. Okay, so if we all are on the same page about that as healthcare professionals, we have a responsibility to have our focus firmly set on the health of individuals and populations. Then, if you ask yourself what determines the health of those individuals and populations, we instantly can see that it's not just about us being well trained and able to deliver healthcare to the patient in front of us, but it's also about influencing, advocating for, paying a heed to all those wider determinants of health. We all know very well now that, for example, mental health is not something that you can simply treat by, as I say, taking a bottle of pills off the shelf. You've got to understand the determinants of it. The same with with physical health conditions. You've got to understand the determinants if you're going to be able to treat your patient to best advantage. So I would say to any health professional at any stage of their careers, it is not enough to say, I'm just going to focus on treating this patient in front of me. That's reneging on your wider responsibility to think about what are the determinants of health. Am I actively lobbying against the tobacco industry? Am I actively lobbying to try and turn back climate change? Am I actively lobbying to ensure that we've got a health service that is fit for purpose? All of these things are going to affect the health of our patients and the whole population. And so as healthcare professionals, I think we've got a responsibility to not put our heads in the sand and say, actually, that's somebody else's responsibility. It's our responsibility too. And we should be speaking out on behalf of all of these aspects. And I'd add something else. I'd say that it's the responsibility of our professional organizations too. How often have you heard a professional organization say, actually, that's for the political arena? I'm sorry. Climate change is a health arena, and we as healthcare professionals have got a responsibility to speak out.
Along with speaking out, what tools do we need to provide the next generation of healthcare professionals to address the health inequalities?
So in the last 100 years, we've seen a large shift away from infectious diseases towards more long-term health problems. That's notwithstanding the recent COVID-19 pandemic, which has brought infection back to the fore. But typically, people are now living generally quite long lives. So the kind of lives people lived 100 years ago, where you might die in childhood or as a young adult, are thankfully largely over. People are now living much longer. But it doesn't mean they're living with long-term health conditions rather than acute medical problems that you can solve very easily. So rather than infection where you can give antibiotics and cure them, people who've got high blood pressure, diabetes, kidney disease, asthma, etc. They may be smokers, may drink heavily, may not exercise enough, may have a poor diet. So for these factors, there's no simple solution, no simple pill, no simple intervention. It requires long-term sustained intervention from health professionals and from wider society. So I think in terms of future training of doctors and other health professionals, it's very important that they're trained in things like, for example, behavioral science. So knowing what factors drive people's behavior, how to change behaviors, things like health coaching as well, which will become very important so they can influence people in terms of improving their health. Of course, they still need to know all the traditional medical skills, such as how to take history, how to examine, how to prescribe drugs and so on. But we're finding increasingly that simple interventions only go so far. So for more complex interventions, we do need to educate our future doctors with skills in areas like health coaching, for example, and behavioral change.
Thank you so much, Azeem. And so coming to you, Habib, what role does the next generation of healthcare professionals have?
Well, I think the current and future generations have a huge role to play in reversing the dial, I guess, on inequality that we see in society. But when we think about race inequality, we need to look at it in its global perspective, the global framework, because when we think about white majority countries such as the UK or Canada or the United States or Australia or New Zealand, we find that Black and minority ethnic communities in general do less well off. They do less well in terms of health and the health inequalities that we see, in terms of wealth. And we know of the race pay gap. They do less well in terms of educational attainment. They do less well in terms of law enforcement and being on the wrong side of law enforcement. And they do less well in employment in terms of opportunities, in terms of the experiences that they receive within the labour market. So we need to look at not just health inequalities on their own, but we need to look at the root cause or the structural causes of those health inequalities. And that, yes, that includes looking at the way that society has been structured, not just over years or decades, but over centuries, to give us exactly what we've got. And so we need to look at the structural causes of the inequalities that we see. Within the race field, that doesn't just mean Black and minority ethnic people standing up and talking about their lived experience, but it should also mean looking at and thinking about and talking about what it means to have privilege, not just within our health system, but within society as a whole. And until we have those conversations in an open and transparent way, we will not be able to shift the dial on the inequalities that we see within our communities.
And we do hope to have these conversations in the near future. However, building onto this topic of the role of the healthcare professional, this past year we have seen doctors addressing some of the inequalities that are not exactly within our control. For example, climate change. So this comes to a question on who should be leading these movements that are not exactly related to healthcare professionals. Does it fall on us, or does it fall on other sectors?
Well, other sectors should certainly, I mean, as citizens, never mind our doctor hats, as it were, but as citizens, we should be taking an interest in and advocating for those causes which are equitable and fair. But where we come in as doctors is that we do have the respect in the main of the public, and therefore with that respect comes responsibility to try and make the case. So, for example, this is why when the medical professions got involved in the climate change argument, it was a very powerful moment in time. I mean, I remember this vividly, that for a long period, there was a view that actually climate change was for someone else, it wasn't for doctors. But it was only when the case was made that actually climate change is a powerful determinant of health of populations everywhere, that slowly conventional medical thinking changed, and the medical professional organizations started to realize, actually, this is for us.
So Neena, as a follow-up on the role doctors play in tackling our patients' inequalities, you currently sit on various boards of professional organizations, and you're also a neonatal specialist. Thus, if someone was in the same position as you were, what role would they have, let's say, in child's health?
Sure. So I would say, let's take child health. As you raised the issue of child health, and I'm a neonatologist and a pediatrician. So child health is the end result of many, many, many different factors. And we would be naive and disingenuous if we suggested that we as healthcare professionals are the sole guardians of child health. Clearly we're not. How a child is brought up, the experiences they have, the exposures they have. Let's take smoking. You'll remember huge discussions about whether or not smoking by adults with children in their cars should be permitted or not. That's an example of why we need to get involved in these broader issues. Every pediatrician knows that secondhand smoking is damaging to children. It's also damaging to the fetus. So a woman who smokes damages her baby, but a woman who breathes in secondhand smoke is also, through no fault of her own, exposing her baby to problems that will stay with them for the rest of their lives. Surely we as healthcare professionals have got an obligation to speak out. Now, if that brings us into conflict with, for example, the tobacco industry, well, so be it. What we should not do, though, is take political sides. And I think this is perhaps the line you were alluding to. and where people sometimes get and feel a little bit hesitant. I think we can speak from the perspective of healthcare professionals who are expert in our own area, who understand the determinants of health and who understand how to treat diseases and prevent ill health. But what we should not do is take political sides, and we should present an argument to everyone across the political spectrum. Now, if it turns out that the government in power is particularly doing something that is counter to what we're advising, then it's very easy to be told you're meddling in political affairs. And that's why I think what we have to do is say very, very clearly, we are addressing our comments across the board. We are not making a we're not making a politically biased statement. We're simply saying what is correct from the point of view of our knowledge, our experience, and our expertise as healthcare professionals.
So this kind of leads on to my next question. As healthcare professionals, we want to advocate ways that tackle our patients' health inequalities. And so this questions whether we should have a political platform to stand on. Should doctors get involved in politics?
So I'm not sure that doctors should get involved in politics necessarily, but I do think doctors should get involved in political debate. There's a difference. I tried to explain that difference by saying we shouldn't be saying, you know, Party X is doing a great job and Party Y is doing a terrible job. We should be saying, hey, Party X and Party Y, let us just tell you what we think about the problem of, for example, child obesity. Now, it's clearly the party that's in power that's going to be most likely to be able to do something immediately. But it's also don't forget, in a democracy, an opposition party also has responsibilities. The responsibility of an opposition party is to challenge the government of the day, to hold their faces to a mirror. And therefore, the advice that we can give should be directed at both sides of any political divide.
Thank you so much, Neena. And so moving on to the patients themselves, how should the patients put their health first when addressing their own health inequalities? Because obviously everything should be about patient-centered care. The patient should have the voice. Patients should make their own decisions, etc., about how they want their healthcare to be like. So how should we make sure that the patients put themselves first?
This is where education is very important. So as doctors, we can do a lot, but we rely a lot on the education system to educate people about health, things like health literacy, for example. So it's very important we work, the NHS work with schools, for example, to ensure that children are educated in things like health and health behaviours, and that carries on through college and university. So I think we have a role, but we need to work with wider society to address that issue, because people who've got better levels of education and better health literacy will always do better in terms of their health outcomes, because they're able to read more, understand their diseases better, understand prevention better, and more likely to take action to improve their health in the longer term. So I think it's about working with wider stakeholders. So it's not just for doctors, it's for wider society, especially education in schools and universities.
Working with a wider society with policies to ensure health equity, such as educational policies. However, coming back to the equity issues, how would they affect how a country approaches universal health coverage, UHC? And what advice from your positions, where we're all working in a country that has more experience of UHC, would you give to these countries?
Very good question. So the concept of universal healthcare or universal health coverage is one that's gained traction over the last decade or so. And essentially, one understanding of it is that countries' governments have a responsibility to make sure that every citizen can access healthcare. Let's take that as the definition that we're using today. But if you do accept that as the definition, it then begs the question, is there an equity element in considering how that universal health coverage or universal healthcare should be provided? And I would argue that the UK's National Health Service, as originally conceived and as it was delivered for the best part of 50 years, actually provided the most equitable approach to delivering universal healthcare. And it did that because it was not only publicly funded, which meant there was a social contract, we all pay into it according to our means and we all get out of it according to our needs, but it was also publicly delivered. And there are great strengths, there were great strengths in the UK, and there still are great strengths, though they're being eroded at the moment. There are great strengths which the UK has been an exemplar for having not only a publicly funded, but also a publicly provided healthcare system. And this made for great equity. So my point about equity, I think everyone accepts the equity argument in relation to publicly funded, but I'd like to put to you the equity argument in relation to publicly provided. Now, if a healthcare system is publicly provided, by that I mean it's delivered by a public sector workforce. In other words, doctors, nurses, healthcare professionals who are employed by the state. And they work in facilities that are managed and owned by the public sector, by the state. And that's essentially what we had in the NHS for many years. You, me, all of us, we are employed by government, we're employed by the NHS. NHS is a public sector organisation, and hospitals, NHS hospitals similarly, are not owned by a third party, but are also owned by the NHS, which was a government body. Now that meant several good things. It meant that transactional costs are minimized because you're not paying a third party to be an intermediary. You're not paying, for example, you're not paying a body who will then go out and pay other people to actually deliver the service. So you're eliminating a lot of waste, huge transactional costs there. By having a workforce that is a public sector workforce, it means we're all on a level playing field. And the NHS workforce used to be treated very, very well indeed. It was valued. We had decent pay, you know, we weren't all incredibly rich, but we had very good pay, and we were secure because we also knew we had a very good pension to look forward to. We also knew that we didn't have to keep looking over our shoulder at what our neighbour was earning because we were all in it together. There was an absolutely transparent standard pay structure and everyone knew what everyone else was being paid pretty much. So we weren't distracted by wondering what our neighbour was being paid and chewing our nails because we were fussing about whether or not we were being paid what we should be paid. So we can actually focus on doing what we were meant to be doing, which is looking after our patients. So it worked well from an economic point of view, no or minimal transactional costs. It worked well from the point of view of having a workforce that was content and therefore gave their all towards their patients, which is what you want. And it also meant that you didn't have these very destabilizing elements creep in, which is what you have in many, many countries around the world where you have parallel private and public healthcare systems.
However, the society has changed, not just in the UK, but across the world. The number of inequalities within the system have increased massively, not just even a small amount, which some say this makes the system much more undeliverable, as this type of system was a time where the burden of equity was much less. And so, what is the solution to this moving forward?
I would say that there is a lack of understanding of what a good health service is and what good healthcare is. Because if you take, let's take an extreme example, which of course is the United States, which has got a very, very commercialized healthcare system. And let's look at the relationship between their healthcare system and their measures of population health. And you will instantly see that the money that you spend on your healthcare system and the absolutely state-of-the-art, wonderful, wonderful provisions that are available in the United States, which people fly in for all around the world, are not actually leading to a healthy population. So you're quite right. It's a classic example of huge, huge, huge inequity. What's the solution to that? The solution isn't more of the same. We've got an experiment that has been clearly shown to be flawed. So let's think again. That's one point I would make. The second point I'd make is that do not the wealthy realize that they are also being exploited in a marketized healthcare system? It's very often said a marketized healthcare system disadvantages the poorest. That's not true. It actually disadvantages everyone. And I give you an example of, for example, let's say if you're wealthy, you're very susceptible to products. For example, you can purchase your whole body scan, your personal genome screening, your health check at regular intervals. There's absolutely no evidence that this does anything to safeguard your health. All it does is put money in the pockets of those who are selling you these services and raise your anxieties. It makes you part of the huge worried well. And it has another destabilizing effect because, of course, in the UK, if you go off and get a personal genome scan, for example, and it comes up with some quirk that makes you incredibly worried, what are you going to do? You go heading off to the NHS and say, help, 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 help. Something's been discovered that needs to be further investigated. So here are you, the worried well, you spent your money in the private sector and you're now going to be an absolute drain upon the public sector. Very, very clear example of how destabilizing this is. It hasn't given you, the wealthy well, any peace of mind. It's really given you huge anxieties, taken money out of your pocket. You've not benefited at all. So you don't realize that you're being exploited too.
You do make a good point. But bringing on to the topic of finances. So coming to you, Azeem, you have just recently published a paper, a study called Patients with Comorbidities Have Better Detection of Chronic Conditions but Poorer Management and Control. So many patients, especially the aging population, have multiple chronic conditions. Taking note of the increasing amount of the aging population, how can we improve the access to the healthcare system, for example, for managing chronic conditions, without causing a financial burden on the healthcare system?
Claire, yeah, that's a very good question. So increasingly people are now living with complex multimorbidity. So in the past you might have had just one health condition in your old age. Now, because people are living longer, their treatment is better, they're surviving much longer. I might have 4 or 5 conditions, so diabetes, chronic lung disease, high blood pressure, heart disease, etc. That does make managing more difficult because a lot of our guidelines are written for one disease only. And so when you apply these guidelines to an individual, I end up on multiple drugs. For example, sometimes those drugs may cause adverse drug reactions when they interact with each other. And so we need to shift towards thinking about guidelines that are not just for one disease, but are for complex multimorbidity, so we can better manage these patients in the future. And through better management, better control of risk factors, better prevention, we can improve these people's health and thereby their impact on the health system. So it's very important we think about how we manage multimorbidity in a holistic way and not just treat a patient as, say, a combination of 6 different diseases. We think of that patient as one person who happens to have 6 diseases that need managing together and not separately from each other.
Thank you, Azeem. And so more and more health equities are becoming more transparent. When looking across the world and the success of dealing with the pandemic, resources are not the issue when delivering high quality healthcare, but actually factors such as leadership play more of a critical role. So my question comes to the factors. What factors should be assessed when identifying a good healthcare system?
So I'd like to just start by re-emphasizing something I said a moment ago, and that is that universal health coverage as a concept has been very powerful and is very good. But it is limited if it doesn't also take into consideration how universal health coverage is provided. And at this point I put to you, I would say that one should seriously think about how one delivers universal health coverage, not just stop at its delivery. And I've given you what I think is the best approach to that. But let's take your second point, which is the issue of widening health equity and widening disparities in the world today. And let's put it in the context of COVID, because that's where we are at the moment. So COVID was dealt with by, well, it was science that really led to identification of the pathogen, it led to sequencing of the genome, it led to developing very many vaccines, and it led to actually starting to test those vaccines in clinical trials, and also it led to doing clinical trials for treatments for severe COVID-19 disease. So science was at the heart of how the world responded to COVID. But of course, and it was basic public health measures: isolate, test, trace, isolate, quarantine. Basic public health measures from the 18th to the 19th century, understanding that actually it was crucial to the global response to the pandemic. Of course, inherent within that, we've now got an economic downturn. But let me put this to you: how is the economic downturn and the way in which it's being addressed being measured? And bear with me, because this might seem a slightly long argument, but bear with me, please. So it's all being discussed in terms of GDP. What is GDP? GDP is a measure of products and services which a country produces over a period of time. But what actually contributes to the stability and the resilience of a country? Surely population health is at the heart of it. If you don't have a healthy workforce, if you do have a population that's crippled by multi-morbidities, chronic non-communicable diseases, obesity, you're going to see what we are seeing in many wealthy, not in many, in some wealthy countries today, chief amongst which is the United States, which has seen, so last year I think it was, maybe the year before, saw for the first time a reduction, a reduction in longevity. Heavens above. This should be a wake-up call for every healthcare worker in the world. So I say to you, we should be factoring population health into GDP, and we should be factoring the determinants of population health as a product that is important for GDP. But that's singularly not the case. Let me give you an example of a woman who breastfeeds. Breastfeeding isn't, you could conceptualize it as a product which is feeding a baby, but also contributing to that baby's lifelong health. Is breastfeeding included in GDP? No, it's not. GDP is a flawed marker for a nation's well-being. And this is really, really, really important in a post-COVID recovery era, because we are talking about metrics that belong to the last century. We are not talking about metrics that incorporate population health, which is an absolutely cardinal, crucial component of how well a country is going to recover from this pandemic, how it is going to be resilient going forward, and how it's going to have a healthy workforce to sustain itself in the future.
So Neena, you bring up a very interesting point regarding GDP. And so what markers should we be using to assess our population's health?
Yeah, so GDP is often used as a metric for development of a society, but actually there are measures we can use. So one is clearly life expectancy, which tells you how long people might live. Then there's healthy life expectancy, which is how long people might live in a healthy state. Then we measures like quality of life, for example, those are also very important. And in fact, when we looked at international studies of quality of life, we find the countries that do best tend to be those in Scandinavia, so places like Sweden, Norway, Finland, Denmark. That's where the public tend to report the highest quality of life and highest health levels. So the two do go together very closely. So by itself, GDP is not always the best metric, because there are societies where, like you mentioned, the USA, where the GDP levels are very high, but there are very large inequalities between different groups of the population. So some groups are very poor, some are very affluent, some are very short life expectancies, others much longer. So I think we need to look at other metrics, such as quality of life, and not just GDP, and also things like health equity as well. So that's between the most affluent and the most deprived in terms of quality of life.
Measuring health inequalities isn't easy. we know that. And it particularly isn't easy when we're not looking at the right thing. So if we're looking at the root causes and structural discrimination, and in terms of race, structural racism that we have within society that contributes to the inequalities that we see, then measuring that will be challenging. However, we've got a number of things within the NHS that we've been focusing on that to look at how we can measure and how we can respond to some of the challenges that we see. In the workplace, for example, we've got something called the Workforce Race Equality Standard, which measures the performance of NHS organisations against 9 indicators of staff experience and opportunities. So, for example, where do staff find themselves on the pay scales? Comparing black and minority ethnic staff with white staff. The relative likelihood of staff going through a formal disciplinary process, and again, you can look at that. The makeup of the board of an organisation, the leadership of an organisation. With regards to communities, we in the NHS have launched a new kind of a new body called the NHS Race and Health Observatory. And the Race and Health Observatory will do 3 things, I guess. Firstly, it will look at and catalyze and facilitate high quality and innovative research, not just on those health inequalities that I've mentioned before, but also on the structural causes, root causes of the health inequalities that we see. Secondly, it will turn that research into insightful action and strategic policy recommendations for implementation. And then thirdly, it will look to support organizations to implement those recommendations. So the observatory, yes, by its very name, it will observe, but it will not just observe, it will also speak and it will also act as well. Over time, we hope to transform some of the deep-rooted, long-standing health inequalities that we see across our society.
Wonderful. So this kind of brings me on to my last question. What is the future of health equity in our health system?
Well, the future of health equity will depend upon this generation and future generations. We need to look forward, but we also need to look back in order to not make the same mistakes that we made in the past on this particular agenda. When we look at race and ethnic health inequalities, which is my focus, I know that that particular agenda should not be the burden for those that are most affected by it. Everybody has a role to play in order to close down the gaps in the discrimination and in terms of the disproportionate impacts that we see within health and beyond health across society. And yes, that includes having allyship on this agenda of race and making sure that this is a responsibility of everyone and everybody shows leadership on this agenda for the benefit of our health service and our patients and communities as a whole.
I think there's 2 separate issues there. One is globally and one is perhaps within the UK. So globally, the key thing is getting people universal health coverage. So it's been shown across the world that if you can give people access to a basic range of health services free of charge or at very low cost, that does improve people's health and quality of life. So globally, that's still a big challenge because there are many countries with very undeveloped health systems where people have access to good health services, or it's very costly in terms of income to access those health services. So globally, that's a big challenge about how we ensure that societies do offer universal health coverage, or at least a basic package of healthcare. And even in rich countries like the USA, there's still many people who don't have good access to a wide range of health services. In the UK, it's a bit different here because we have got an NHS which offers free access to healthcare. The challenge is more about how we prevent ill health, how we minimise use of health services through prevention, through early diagnosis of disease, and through managing long-term health problems as well. So times are a bit different. We've got challenges in other areas. So one is funding. So clearly, the NHS, its spending is going up year on year, both in absolute terms, but also as a percentage of our GDP. So another challenging question is how we ensure we maintain the economic viability of the health system in the longer term, particularly as the population ages more. And so we've got fewer people working compared to those who will retire from work. So we think about how we can maintain a high quality health system in an era when the population is going to age.
Thank you so much. I think you both brought up some great points. And so I think this is an issue for my generation or the next incoming generation of healthcare professionals, is that we don't know what to expect for our healthcare system because we haven't been taught it. We don't have any role model healthcare system to look at. So, Neena, coming to you, what is the dream healthcare system?
Publicly funded, publicly provided, well-governed, a happy, stable workforce, and very, very clear mechanisms for measuring outcomes and quality. That's it in a nutshell.
Thank you, Neena. On that note, this brings us to an end to tonight's episode. I want to thank all the speakers joining us tonight on this critical episode on health equity. I have clearly learnt a lot. For example, the role doctors play in addressing the health inequalities on a regional, national, and international level. As all the speakers voiced out tonight, everyone has a role to play in order to address the inequalities and advocate for those causes that are equitable and fair. So thank you for watching tonight's episode. I'm Pedra Rabiee. I'll pass it on to Johan now.
Thank you to everyone that made tonight's episode possible. Whenever our scholars are thinking about complex problems facing our health systems, we encourage them to think about how they make significant change in the world of healthcare. We are incredibly lucky to have some incredible scholars in the HLA. They use the HLA as a platform to take their ideas and bring them to fruition. If you are interested in the work of the HLA, why not join us at one of our future HLA events? Why not join one of our programs? Why not even become a HLA scholar? Thank you for joining us. My name is Johan Majeed, the Director of the HLA, and it's a good night from all of us.